Uh, Thank you. The last webinar of 2022, we have had a very successful year of webinars, and we really look forward to a very successful year going forward. My name is Susan Elliott. I'm at the University of Waterloo. For those of you who don't know about the University of Waterloo, we're most famous for having invented the BlackBerry. And my co-chair, Katrina Plamondon, is otherwise engaged this morning. She's at the University of British Columbia at the Okanagan campus. We are looking forward to a really exciting 2022. I think I said 2021 last webinar, 2021, but I was looking forward to 2022. We're looking to actually have a series of touch points with our community where every other month we will have an in conversation with. So we recently had an in conversation with Steve Hoffman, the CIHR Population and Public Health Scientific Director. And that was really, really useful. That was a members only, by invitation only activity, and had a really, really good conversation with Stephen. And we're looking forward to having every other month a in conversation with in 2022. So we're thinking of having an in conversation with IDRC, in conversation with vice presidents international from some of the top universities in Canada. And if you have ideas for people you'd like to have a conversation with, please let us know and we'll see if we can arrange that. On the opposite months, we're going to have substantive webinars about topics like this. So again, if you have an idea for a webinar that you'd like to do, please be in touch with Lauren and she will get in touch with Katrina and myself. Because we look forward to having lots of informative conversations in 2022. One of the silver linings of the pandemic has been this opportunity to have these great exchanges in a virtual world that we might not otherwise have been able to have. So we really look forward to that in 2022. That's enough of me and my introduction. I'm going to turn everything over now to Charles Larson, who's going to take us through this amazing webinar. Over to you, Charles.
Thank you, Susan. Good morning, good afternoon, or good evening, as the case may be. Bonjour, bienvenue à tous. The title of today's presentation is Transitioning to Scale, Promising Innovations. Essentially, it's about taking a promise and making it a reality. I will be your moderator today. I am a professor in the School of Population and Global Health at McGill University, and I am a member of the Grand Challenges Canada Transition to Scale Investment Committee. And I'm joined today by three panelists that I'm extremely pleased are able to join us. They all, one way or another, have a connection to Grand Challenges Canada's Investment Committee and the Transition to Scale Investment Committee. So I'm going to introduce all three. I'm going to say a few words about what transitioning to scale means, and then we'll open it up for questions to our panelists. And then hopefully we will have time for questions from all of you and try to hold about 10 or 15 minutes for that. So if I could begin with Cedric Bisson. Cedric's a partner in Terralis Capital, Canada's largest technology fund of fund management organizations, where he focuses on healthcare and life sciences innovations. He spent the past 2 decades creating, building, and advising innovative businesses. Dr. Bisson obtained an MD degree from McGill University and a law degree from the University of Montreal. Cedric serves as a member of the Grand Challenges Canada Board of Directors and its investment committee. I see that my battery is running low, and if you will just give me 1 second, I'll plug in my computer. I apologize for this. I should have done that beforehand. Second panelist is Tina Marie Assi. Tina is co-director of Global Health Innovation at Grand Challenges Canada. In this capacity, Tina is Grand Challenges Canada's lead on sexual and reproductive health and rights for the organization's Transition to Scale portfolio. and provide strategic oversight on Grand Challenges Canada's seed portfolios in global mental health, maternal, newborn and child health, sexual and reproductive health, and early child development. And our third panelist is Matt Waynes, and I have spelled his name incorrectly. Any of you who are looking for Matt online, it's W-I-E-N-S. My apologies, Matt. Matt is an assistant professor in the Faculty of Medicine at the University of British Columbia. He's an epidemiologist and public health researcher with a strong focus on pediatric sepsis, mobile health, and health system strengthening. And for the past 10 years, he has led the development and implementation of a series of transitioning to scale studies, several of which have been funded through Grand Challenges Canada, aimed at deriving and validating clinical prediction models for post-discharge mortality. So let me just, I have two slides here, and I just thought I'd start with a definition so we're all at the same starting point. So we're going to define that as the cumulative research and parallel system requirements necessary to move from proof of concept to positioning and innovation to take it to scale while maximizing potential impact. So it's really about an innovation that's gone through proof of concept with the hope that it'll eventually meet its full potential, become a reality. But it's important, and it's not well understood, that you don't go from proof of concept to reality. You need to be considering a number of steps, which we define as those steps connected to transitioning to scale. And so what does it look like conceptually? Here, you start with an idea, you know, that you create a moment, and then you refine that idea. You test it in terms of, you know, the discovery pieces of research. This leads to knowledge generation that helps you then put together protocols that deal with proof of concept. So does it work? Does the innovation work? That's development research, which involves efficacy and effectiveness studies. And it's only after that then that you move into this transitioning to scale arena of research, which involves implementation research, impact and cost benefit determination, and knowledge translation. But it also has several other parallel considerations. You know, what are the alternative pathways to scale? Public sector, private sector, combinations, partnerships, and team building are critical. Health system integration, regulatory approvals, policy, public health policy. Things are not going to move forward without policies and support of the innovation. And then perhaps most importantly, considerations of financing and a sustainable business plan. And finally, I should point out that many people who are very good at proof of concept really don't have the skills to move to transitioning to scale. And it is very much about passing on the torch to those who have those skill sets. So I'm going to end there, and we're going to now start with the Q&A. And I'm going to ask to Cedric, I want to begin with you. And in your experience, what are the greatest challenges one will face in transitioning an innovation to scale?
Well, thank you so much. And I will start first of all by saying that at Grand Challenges Canada, we really work on innovations that go beyond the pure technical gadgets and widgets. And a lot of the innovations that we have are really social innovations or social programs. And so we try at Grand Challenges Canada to transition a series of innovations of all kinds, many of which are more of a social or programmatic nature. So that being said, and I'll make my comment in light of this, because of my background, you might think it's only tech, but it's actually a lot more, significantly more than tech. The vast majority actually are not technical gadgets and new drugs. So that being said, I think your slide really summarized some of the key challenges. I think I would potentially highlight three. The first one is that there is often a vast difference between an initial pilot program done in a controlled setting where the variables are somewhat measured, and then rolling out at least in a wider scale, perhaps not at the country level, but at the regional level or local or multi-local level. There are multiple different variables that may not have been seen, may not have been analyzed. The environment might be different. And so totally understanding why something worked in a small setting before transitions and why it could work in a larger setting is really important. That would be the general point. In order to do this, I think there's 3 or 4 things that I think are critical. The first one is to understand what is the imperative for transition to scale, who will be affected by transition to scale, who could be potentially negatively affected by the transition, and what could be some blockers to what could potentially be an otherwise great idea. A lot of the projects that you and I worked on, Charles, seem to make a lot of sense intuitively, yet they're very tough to transition. So why is it that there's some blockage? You have to dig deeper to try to understand. There might be counter incentives or counter reasons that are not immediately obvious for these things to actually not really materialize. That would be one thing to look at. The second one is human resources. We are highly dependent on human resources for transition to scale at all levels. And I'm not talking about technical staff and engineers. We do need that in some of the digital projects, but in many cases, we're talking about training nurses, training healthcare practitioners, working with people within the Ministries of Health, working with those individuals. And in some cases, those people, training them is difficult, retaining them is difficult, they may disappear. I was involved, as you know, in a project in Cameroon where we lost some of the key staff. Of course, COVID was a challenge, and so that is definitely a huge challenge. And having people that understand how to scale up an initiative, business or non-business, is really, really critical. And in a developing country setting, it is even more critical in training them. The third thing I think is interacting well with government agencies and government ministries and NGOs that will be ultimately responsible for owning this. GCC is a financier, doesn't actually operate the transition to scale, and understanding and making sure that at some point the innovation becomes part of a programmatic thing, which is within the healthcare system in the region or country or province of interest. And that's typically extremely tough and long lasting. You will notice that in my comments, I did not mention 2 things that perhaps others might have mentioned. I did not mention money, and I did not mention technology. So of course, we need cash, we need dollars, and we need technology to transition things to scale. And of course, these are important. But the reason why I did not mention those was that I think the other factors are often overlooked, but critically important elements to actually achieve transition to scale. Yes, we have to spend on, we need dollars, we need smart partners to actually put money to make that happen. But with money and none of the previous factors, projects will be a failure. Similarly, a nice technology without any of the rest will just be a nice technology that will remain at the local level. So I'll stop there because we have a few learnings from, we've been working almost a decade on this, Charles, and I'll let others perhaps talk more about that.
We'll come back to you in a few minutes, Cedric. I'm going to move on to Tina, and before I ask this question, I'd like to point out that Grand Challenges Canada, through the Transitioning to Scale Investment Committee, has invested almost $100 million over the past 8 years in support of projects that need to and are asking for funding to support that transition to scale period. So Tina, I'd like you to briefly describe Grand Challenges Canada has defined 4 stages of transitioning to scale. And I'd like you to just briefly, for our viewers today, to describe these stages and the rationale for them.
Sure, thanks, Charles, and thanks, Cedric, for laying out the important considerations when we are proposing investments at the transition to scale level. Just by way of background, Grand Challenges Canada invests at 2 levels. The seed level, which is funding up to 250,000 Canadian dollars to really test proof of concept, as Charles alluded to. And then those that float to the top in those portfolios portfolios that really demonstrate achievement of proof of concept, promise for scale and sustainability, that they are adding value relative to incumbents or alternatives in the market. And for those where Grand Challenges Canada has a real value add, arguable value add to play in the investment, those ones are considered for investment at the next level, which is the transition to scale investment level. And that program is designed to provide funding up to 3 million Canadian dollars for anywhere from 3 to 5 years, typically. In the past, the funding amount was tranched in a large envelope to the innovator. And what we learned was that not all organizations are adequately prepared to manage an influx of capital of that magnitude. And so to de-risk the investment from both the innovator's perspective, but also from Grand Challenges Canada's perspective, we worked very closely with the investment committee in the last couple of years to develop an investment phasing framework where we now have 4 phases of investment within transition to scale, which we call TTS 1, TTS 2, 3, and 4, very original. But essentially, those are stages of an innovation's development that has programmatic milestones built into them to best position innovators for long-term success in terms of achieving scale and sustainability and ultimately big impact. So starting with transition to scale phase 1, this phase is really designed for innovators who have achieved proof of concept, who know that they want to go to scale and replicate their models, but haven't really figured out their business plan yet, what their distribution channels are going to look like. And they really have to do some of that preliminary planning before they actually take their innovations to scale. The goals of that funding are to develop a viable plan for scale and sustainability and generate necessary evidence to graduate to the next phase. So here we'll provide roughly $150,000 to $250,000 for innovators to start understanding customer or user needs, pain points, to develop an initial customer proposition, to develop scaling plans or business models, things of that nature. And those are usually time limited to anywhere from 6 to 8 months. For those innovators who have their business plans, who understand, generally which scaling pathways they plan to embark on with their innovations, who've achieved proof of concept, they'll come in closer to a transition to scale phase 2 award. And this stage is really designed to provide additional support where further validation of either the business plan or model is needed, or technical elements of the innovation itself. And so objectives of this phase are to validate the viability and the scalability of the business or scaling plan, to address any gaps in evidence needed to scale, and to address any key personnel gaps, because HR is a huge factor of consideration. The next phase is, as you might have guessed, transition to scale phase 3. And this is really designed for innovators who don't really require any further validation of their business plan or their scaling model, where all of the kinks in theory have been worked out around the innovation itself and the generation of evidence around health outcomes. And importantly, at this phase, we do expect that funders and scaling partners are identified, are around the table, and where there's evidence of strong commitment from those scaling partners. So the use of funds at this stage typically will go to building organizational capacity to scale, for example, around systems, processes, talent, and assets, to grow and strengthen strategic partnerships, the leadership team, and to demonstrate evidence of potential government buy-in for scale up as necessary. The final phase is transition to scale phase 4. And this phase is really designed for innovators that have successfully validated their business scaling plan. That's complete validation of the innovation itself is complete as well. But notably at this stage, we do have an expectation that exit partners or exit strategies have been identified with strong evidence of commitment. And this phase was only recently introduced in the last year or so. And so we're very, very selective at who we propose for investment at this stage and who we recommend to our investment committee. So I'll stop there and I'm happy to take any questions on that during Q&A.
Thank you, Tina. Our next panelist is Matt Wains, and Matt has lived this for the past 10 years. He's worked his way through, I believe, each of these stages in developing a fascinating project around what's titled smart discharges. So Matt, I'd like you to sort of briefly describe that pathway that you followed with smart discharges and tell us a little bit about the program, the innovation itself.
Yeah, thank you, Charles. Yeah, I'll spend a few minutes just sort of outlining what we've been working on. Essentially, this all started actually alongside Charles during my PhD. I was a student and Charles was my supervisor, and we wanted to begin to explore the issues of what happened among children who have been admitted to hospital and what happened as they transitioned back to their communities. And our question really was about what happens to these kids? Are they vulnerable after discharge? And is there a way to understand who's vulnerable and who's likely to do well? And essentially what we found was that, as many children die after hospital discharge as die during hospital admission. Most of these deaths that occur after discharge occur at home. So in the absence of additional care. And number three, most importantly, we can identify who these children are with simple clinical predictors that we collect at admission. So with this information, essentially, we went to Grand Challenges Canada and we said, look, we want to develop a program that is focused on targeting vulnerable children and implementing improved post-discharge care, essentially, improved planning at discharge and a follow-up program to ensure that the children who do get sick after discharge are identified rapidly and can seek care early and ideally improve their survival. So, our work has been really over the last 10 years, and it's really, it's quite diverse, but the basic theme of our work is that we are able to understand that children are vulnerable after discharge, understand who those children are, and that improvement in the discharge process and in post-discharge care can actually is able to improve outcomes among these children. So we've called our program the Smart Dischargers Program. We have been working over the last 10 years on various aspects of this. Number one, we had to work on understanding how well this program can work to improve outcomes. So we've done a bunch of different studies showing that this kind of approach can actually improve outcomes. We've also recognized that that these programs have to be implemented within a public health context. It can't be implemented, for example, by a university. So one of our big pieces of this was trying to find the right kind of partner. So initially, Cedric was talking about the different components of this, and I think that one of the key pieces that we think is important is to try to find the right local partnerships on the ground that can take an innovation and essentially build it to the point where it can be implemented in the environment within which it was developed. So for us, we found a local NGO that was very keen on improving health system capacity in Uganda. It's a very strong NGO, and essentially their focus is all about improving the capacity of health workers to deliver optimal care in the context of severe illness. It's called Walimu, and their director is actually the previous director of the Ministry of Health. So there's lots of connections with the Ministry of Health and with trying to integrate programs into the health system. So I think so for us, so there was the building of the evidence, there was trying to find the right partnerships, and then there was trying to figure out how do we actually integrate this sort of this intervention into a real setting. So we had to, for example, build a lot of peripheral aspects. So for example, we had to build a training course, a training program that could be then implemented at at the facility levels to train the nurses on how to improve discharge care. We had to focus on things such as policy transformation. So a big part of the funding that we received from Grand Challenges Canada was actually around trying to change the way that the government recognizes this problem and to change their kind of policies around discharge care. So a lot of the work that we did was engaging with the government and trying to ensure that this problem is recognized and is encouraged to be addressed by the facilities. So we did a lot of work around that. And then ultimately with the combination of evidence, our training programs, and our policy transformation, we ended up implementing this across about 16 different facilities in Uganda. And we really demonstrated that, you know, we can use health workers that are employed by the government facilities to implement this program effectively and ultimately can improve outcomes among children. That's a very high level overview, but that's essentially what Smart Discharges does. Yeah, I mean, I can go into any of the different aspects of that, but you know, there's quite a few angles to touch on, but that's essentially a bird's eye view of what we've been doing in Uganda over the last 10 years.
Thanks, Matt. Cedric, I'm going to come back to you. So financial sustainability is critical. It's probably one of the most difficult steps or phases in transitioning to scale to deal with, and often explains why we have this logjam of innovations that never reach even close to their potential because they just can't find a pathway to financial sustainability. So I'd like to ask you, you know, what do you look for? Or what are the key factors that need to be in place to properly deal with financial sustainability?
I would say, well, first of all, it starts with an innovation who is hopefully either within the transition to scale process or before or shortly thereafter, will demonstrate that it has a medical benefit or social benefit such that the healthcare system can take it over. And that then gives one the case, the business case and the medical case and the scientific case to ask for funds that will ensure that the innovation is indeed used. And that's actually not the same would apply in a developed country context versus a developing country context, right? A lot of the things that we do in Canada, for instance, are not financially self-sustainable. They have to be paid by the government on an ongoing basis. And just that's the way it is, but we pay for them because there's demonstrable proof that they actually are useful. Case in point, certain vaccines, for instance. And so I think the generation of the data set for evidence through the scaling up process or transition to scale process is really, really important. Fundamental, it is often overlooked. Now, that being said, financial self-sustainability doesn't mean, in my opinion, and in the experience of GCC, that it is a business that will generate revenues, profits, and then the profits will enable the project to be self-sustainable. I think that's a overly restrictive business definition. For some projects, this actually applies. So you and I have financed projects, Charles, which are more of a social enterprise where there's a hope that at some point there'll not be enough users of a given innovation, and that innovation ultimately will generate some financial return, which can be pumped back into the system. So there's a bit of that. But in many cases, financial sustainability means that you are able to create a convincing case for a local government authority or a minister of health, or perhaps other organizations to come in and to finance that because it makes sense from a global health standpoint to do so, because it makes sense from a medical standpoint to do so, to reduce maternal or child or early infant mortality and morbidity considerations. And so that is perfectly fine. In some cases, when governments do not have the means to actually cover for things that otherwise they should, and that happens more often than we think in developing country contexts. In some cases, it means that there will have to be ongoing NGO or international aid support. Before the pandemic, I was in Ethiopia, and the health budget there depends on a structural basis from international aid. And so in some cases, financial sustainability for specific projects will depend on those items. So I really encourage a broader view on the definition of financial sustainability than just a pure profit and loss analysis of things.
Thank you, Cedric.
If I can just jump in. Can I jump in there? I really appreciate that latter part that you mentioned, Cedric, about the idea that it's not always just governments taking things on that demonstrate sustainability. Because, for example, in Uganda, much of the health infrastructure and much of the health programming doesn't come from the government. So, for example, half of all care of children in hospitals is provided by private nonprofit. Is provided by the private nonprofit sector, which is primarily mission hospitals, and furthermore, NGOs such as Malaria Consortium, Living Goods, etc., provide a significant amount of healthcare infrastructure in the country. So I think that limiting sustainability to being taken up by the government as the end line sometimes misses the fact that while in North America or Europe, that often is the case, in developing countries, that's often not the case. And expanding the definition of sustainability to beyond just taking up by the government is really missing a huge portion of the medical and social innovations around health that are currently being implemented in these settings. So yeah, and for us, that's a big part of it as well. And I guess one other thing that I want to mention is that the innovation itself, there's often different sort of edges and versions of it that can be implemented in different ways. So for us, for example, we have a prediction algorithm essentially, and that identifies the at-risk children. So how we implement this kind of thing will depend on the context within which we're implementing it. So at certain facilities, it might be a paper-based algorithm. In certain facilities that have infrastructure, for example, within a medical record, it might be integration into their existing medical record. And the training that we do, it might look different based on the kinds of funding that we have. So limiting your intervention to a single thing with a single sort of like, it costs this much, it limits the ability to understand how this could best be integrated in different contexts within that system, and also how that's funded. Because I think that there's many ways to sort of improve capacity that are just beyond, that the government has to take it up. I guess that's one thing that I wanted to mention around sustainability.
I think from what we've heard so far, it's evident that to transition to scale, you need a team with a wide array of skills. And so, Tina, I'd like you to address that issue. And what do you look for in terms of team building that satisfies you and reassures Grand Challenges Canada that this will be a successful investment?
Thanks, Charles. So you hit the nail on the head. The innovations that we consider at transition to scale are operating in very complex environments with a lot of variables and a lot of unpredictability, particularly over the last couple of years where they've been dealing with COVID-19 and health sectors that have been strained in so many unpredictable ways. What we typically look for in the innovation team or the organization team that we're considering is the right makeup of skill sets for the stage of growth of that innovation. So if it's a organization that's still in the clinical development phase of the innovation or still in the proof of concept phase, then obviously we're going to be looking for a team that's more heavily slanted towards research and empirical backgrounds than we would at transition to scale, for example, where issues of scale and sustainability and business planning and stakeholder development and mapping and partnership strengthening are become much more important, even though many of those elements need to be considered from the get-go to some respect. So at Transition to Scale, we are looking for a broader set of skill sets. And importantly, we're looking at the team's ability to identify the right kinds of partnerships, but also to their ability to secure and strengthen those relationships in order to support their intended paths to scale and sustainability. So I would say those are the two things that we focus on. One is the right complement of skill sets on the team, i.e. not a single founder that can do everything, but a strong finance contingency, a strong empirical contingency, a strong partner relations contingency. And then the second is in their ability to establish, form, and secure and strengthen relationships and partnerships.
Thank you, Tina. Matt, yeah, I'm sure you've met many, many challenges as you've passed through this 10 years of transitioning to scale, but if I could ask you to point out one or two of the most important challenges, could you take that up?
Yeah, that's a great question. I mean, I think for us, the biggest at the outset was trying to find the right sort of partnerships. That's been mentioned a few times already. I mean, we started out with it in an academic context. We were partnered with the university in Uganda and the University of British Columbia in Vancouver. And I feel like within that context, it would be very, very difficult to move any innovation to scale in a way that would ever reach sustainability, because that's not the mandate of universities. So we were very fortunate that we found, I think, the ideal partner for us. We found an NGO that was involved in transitioning innovations essentially to scale, focused on health worker training and improved outcomes for severely ill individuals, children and adults. They worked in the areas of hemorrhagic disease, so like Ebola, Marburg. They worked on critical illness in adults and sepsis, and them taking on the pediatric sepsis issue was perfectly in line with their mandate. If we had not found that partnership and that NGO that was closely aligned with the government, our innovation would have purely been just another research project that found some interesting results that would have been recommended to be researched or implemented in a more real life setting, but it wouldn't have moved beyond that. So that was a huge challenge, but it was fortuitous that we found this partnership, and that was what allowed us to build. So that was, I think, the challenge number one. I think the second big challenge is around trying to develop something that can be applied in a wide variety of settings where it theoretically could be beneficial. So in the Ugandan context, this included facilities of different levels. So there's health centers, for example, district hospitals, regional referral hospitals, and then also the private nonprofit sector. Trying to have our intervention be feasible and adoptable in these settings was a huge challenge, and we've learned a lot actually in the last few years, trying to figure out how do we take our innovation and package it in a way that could be implemented in these different settings. And to be perfectly honest, it looks a lot different in different settings than the setting within which the innovation was developed. So our research was done in a fairly controlled way, but the way that it's implemented often looked the same as the way it was done in the research setting. So that obviously can impact how well it works potentially. That would obviously involve additional research to evaluate it in different settings. But trying to find the method within which it can actually be adopted. And even as we've moved through the different TTS 1 through 3 phases, and now we're looking at post-TTS, how do we ensure that what is being done continues even in the absence of any additional funding? And we are currently involved in a lot of planning around that to see how this innovation can continue to persist and have impact in the absence of any additional outside funding. And we're finding ways to do it. It looks different each time, but it's a huge challenge. And we've had a lot of brainstorming sessions around how do we package this in a way that can be implementable. And I think the closest parallel would be something like kangaroo mother care. There's lots of different studies around this, but how do you implement it in different contexts with different kinds of funding and partners is the key to how you can improve care for these newborn babies. And for us, it's the same kind of thing. So those are two things: partnerships and adjustments based on context for implementation.
That's great. Thank you very much. Cedric, why do innovations fail?
A good question. Before I answer, just a comment on Matthew, I would say the partners also may evolve over time as innovations become larger as you go from region to region. So a transition to scale process may involve defining, changing, adding, modifying partners. Why do innovations fail? Many reasons. There's obviously I think in some cases, the 3 or 4 reasons. The first one, in some cases, the business case or actually the scientific case actually proves to be factually incorrect over time. It was the wrong innovation, or there was some obstacle that was not completely foreseen, or something was actually counterproductive to that innovation being actually rolled out. It occurs. It happened within Grand Challenges Canada, whereby some of the projects we tried to scale, we encountered obstacles that were actually difficult to predict. So that's why before you try to scale, you should try to uncover those, but that's definitely one. Another reason why they fail is that some people have incentives not to innovate and not to accept new stuff because they are paid to do certain things in a certain way. They will be paid differently because they don't want to be trained, they can't be trained, or there's no financing for them to be trained, so it causes stress and causes resistance. Sometimes they fail because there's not enough money. That happens, of course, to roll out. So you can't find enough financial sponsors, NGOs, beyond governments and others to actually make that happen. They may fail for political reasons. In some cases, the political environment is not conducive to actually doing those kinds of things. They may also fail for technical and technology reasons. So that's definitely, in some cases, we underestimate, for instance, the requirements for an IT system or an IT backbone or mobile connectivity for that to happen. So there's multiple reasons. I think I'm still an optimist, so I say we still have to try. I think outright failure does occur. What we try to do at GCC is to try to see if something will work through the various phases that Tina was describing, phase 1, phase 2, phase 3, phase 4. So that by the time it reaches phase 4, the likelihood of failure is lower. And so ideally, if they fail, they should fail faster. But there's always a risk that as you scale them up, that you encounter something that hasn't been completely understood. Quite frankly, that's the same in regular business. In venture capital, my other business, a lot of great innovations may initially generate some revenue, and they're never able to scale for reasons that we don't understand. And finally, sometimes there's competition, new innovations, new approaches that are better than the one that you were working on. And in which case, it's fine if they fail, because ultimately the goal is to improve the health of a given population, after all, in global health. So at least this is another reason.
Thank you, Cedric. What advice, Tina, might you give the participants in today's session on, applying for funding through Grand Challenges Canada?
Yeah, so I think the advice I'd give is two-part. One picks up from what Cedric just shared, and it's not being wedded to one single path. The path to success in development innovation is often not linear. And we very much try to live and breathe the notion of failing fast at GCC. We are not opposed to failure. We welcome it. We're a learning organization. We try to learn at every step of the way, and that includes during failure. We welcome new approaches that integrate learnings from past failures. So that would be the first piece of advice. And then my second piece of advice, which is something that we've been focusing on more and more lately, is actually really considering the users, integrating the perspectives of persons with lived experience in the design, in the implementation, in the evaluation, and the monitoring, and in the eventual rollout of the innovations. It pays dividends in terms of just naturally generating demand for an innovation and being able to make smart pivots along the way that address user needs, changes in markets, and things of that nature. And along those lines, I would say engaging downstream adopters and scaling partners at early stages will also pay dividends, in the sense that they will feel like they've been part of the design process, and they will feel some degree of not ownership, but engagement. And typically in those situations, they have more commitment in terms of seeing innovation successfully transition to scale. So that was actually 3 pieces of advice, but I'll leave it there for now.
Thank you, Tina. Matt, Grand Challenges Canada isn't the only game in town. And I know that you've sought support in a number of different funding agencies and avenues for funding. So could you briefly describe what are some of the other sources of funding that one might consider?
Yeah, I mean, for us, it's been a mixture between sort of early phase research, implementation research, and sort of scaling. And our funding has come from a variety of sources. For us, we've had some success with local foundations. So we've had the BC Children's Hospital Foundation be quite involved in our work. They're very keen partners with us from the funding side. We've also worked with different research groups. So Thrasher Research Fund has funded us, CIHR has funded us, but that's really more for the research side. Certainly the Gates Foundation and Grand Challenges program with the Gates Foundation are funders. They haven't funded us. We haven't really tried to get money from them yet, but they're obviously interested in this aspect as well. USAID is a big player in sort of these kinds of programs for implementation work. We haven't also gotten any funding from them either. We've recently partnered with the Malaria Consortium, and they're sort of helping us co-fund some stuff. Again, we're sort of in the sort of, I guess, the early stages of the TTS sort of pathway. So our primary funders have been Grand Challenges Canada, Hospital Foundation. We've had, obviously lots of in-kind support from the Ministry of Health in Uganda. But those are our primary areas where we've received funding. But we always try to pair our funding with additional early research, which can tie into our work. So everything we do is around improved discharge care. So who have we not yet included in our research? So we're looking at like mothers and newborns. So that's one part. We just got some CHR funding from that. We're looking at older children who are over 5. So that's a new area of research. So how can we bring our package to a broader group of patients, essentially? And so we're always trying to combine research and implementation and scaling in the sort of the same sort of rubric, essentially.
Thank you all. I'd like to open this up to those who are participating in this roundtable today. And if you just put your hand up as Susan just has, or put something in chat, Lauren will look for that and read it out for us. So we'll start with Susan and then Vic.
Thanks so much. And particularly, I loved everyone's comments, and especially yours, Tina. I thought they were just spot on. But Matt, I just wanted to follow up with you. And you just led me right down the path, because I work in Uganda as well, but I work with seniors, and I work with a faith-based organization called Reach One, Touch One that actually has a healthcare center in Mukono, funded primarily by Stephen Lewis Foundation dollars. They're the only geriatric healthcare facility in the country, and people forget that Sub-Saharan Africa has the fastest growing aging population in the world. And I came away maybe 10, 15 years ago with the realization that aging is a maternal and child health issue in this part of the world, right? Because it's the grandmothers that are raising so many of the grandchildren. So this is an organization through which you can sponsor a senior the same way you sponsor a child through World Vision. And that provides basic health care, food security, shelter, and social support for the seniors and their dependents. So they get money to send the kids to school. Now the organization also has a school. But what's really interesting is that the healthcare facility now raises 50% of its own budget, because there are no geriatric healthcare facilities in this part of the world. And so people who can afford it are bringing their aging parents here for geriatric care and paying out of pocket. In addition, what the organization itself is finding is that the more you look after older people, guess what? The longer they live. And now they're dealing with the frail elderly, which they've never dealt with before. And they're addressing issues of dementia, which they've never dealt with before. So I loved where your conversation was going about looking at other populations. And I'm going to email you and hopefully we can chat offline. Because I also heard you say, Matthew, that one of the most important things is finding the right partner. And Tina, you hinted at, working in partnership, and we call those things like, we're cheeky enough to call them integrated knowledge translation and co-production of knowledge and stuff like that. And that's how we work with our partners. We would never be able to do the work that we do without our partners. So I just wondered, my question would be, does Grand Challenges Canada do a matching service of any sort where a researcher might come and say, this is the knowledge that I have. This is the research program that I can give you, but I need a partner on the ground.
Okay, hold on to that question, folks. And let's get Vic and Afnan to come in. And Vic, we'll start with you.
Thank you. Hi, everybody. Follows on Susan's question, actually. Matt again, for making him busy, the poor fellow. I'm interested in synergies with other Canadian groups. In Amberara, there's a big University of Calgary group doing maternal child health. The McMaster people are there doing psychiatry. The Dalhousie people are doing micro research workshops. Are these your partners as well in some way? Is there value in not trying to trip over each other and looking for complementarities and so on? So that's my question.
Thank you, Vic. Afnan.
Hi, can you hear me?
Yes.
Hi, everyone. Thank you so much. So I have way more questions than time can allow, but I think I want to go off of what Vic just said. I'm actually working with the WHO on implementation research for non-communicable diseases, and we're just getting a few things off the ground. And I think just as someone who's in the early phases of this work, I'm actually interested in finding out more about synergies as well, and what role as the WHO might play in some of your work, or has it played a role in some of your work, especially with the Uganda project. I'm wondering, we are doing some work with NCDs on the ground and some nonprofits around NCD work, and I'm just beginning to look into that, so I'd love to know more about that. And I also think the question of partnerships, a sub-question that I get is about ethics. So how do you make sure that you're not working top to bottom all the time and the partnerships are equitable, which is a really big question. And also how to not overwhelm the people that you're working with, because I think as someone who's working with the WHO, I realize that, NCDs are just one of the things that people on the ground are being faced with in research. And there's the infectious disease guys, and there's the pediatric guys, and there's a lot of things. So one thing I often feel guilty about is like, oh my goodness, I'm asking so much of these people. So I just want to know, I guess I have a lot more questions around that.
Thank you. Okay, we have about 3 minutes left to solve these problems. And I'm just going to open it up to the panelists. Maybe we could start with Matt, since Matt, they put you on the spot, and then I'll invite others to pipe in.
Yeah, I mean, the issue about partnerships, I know Vic Neufeld, you mentioned about the different groups. So I lived in Amberara for a number of years, and I know all the individuals you're talking about, and I've been peripherally involved in some of those different initiatives. I think, like, for example, the Alberta people, the Calgary people, they are essentially implementing programs. So they're around health system strengthening at the community level. So they're working sort of in parallel to, I mean, and with the government, of course, but it's sort of a different sort of, like, I think their focus is a bit different. They're looking at a lot of community health worker training, things like that. What we're trying to do essentially is trying to really work with the policymakers, and then have them direct us to, okay, well, which facilities, which hospitals should we be working in to deliver these programs? I guess it's sort of, in some sense, similar to what the Calgary group is doing. Like, so they get funding from wherever they're getting funding from the government of Canada, and they're implementing this training program for VH. And then we're getting funding from Grand Challenges Canada and our other partners, and we're essentially implementing the Smart Discharges program in various health facilities around the country based on the needs and the enthusiasm for partnership. we certainly are not really stepping on each other's toes. I think there's not enough synergy, to be honest. And I think one of the issues with academic partners is that they tend to be a bit too academic, they're not always quite as practical, and they're not able to pivot as easily as an NGO partnership. And I think that's one of the issues that I have seen play out with Mbarara University related projects, because they still maintain a bit of their academic sort of spin. Sorry, I don't take up too much time on this.
Thank you.
That's how I see that.
Tina, Cedric, any brief comments?
Sure, I'll just jump in quickly on the idea of matching that Susan, you raised. We don't necessarily do matchmaking in a systematic way. At Transition to Scale, it is a much more bespoke process than SEED program. So our portfolio leads will, where appropriate, identify potential synergies across the portfolio, across the innovators that we're supporting, and make connections. But that's kind of a side of desk activity. Our formal way of doing this is actually through the program support platforms that we have for each of the portfolios.
Okay.
And part of the work they do is convenings, annual convenings, now virtually, but historically in person, to bring the ecosystem together, to provide networking opportunities, and a number of partnerships we've documented over the years have emerged from those activities. So that's one way. I'll stop there as well. And Cedric, if you have any.
Cedric, you get the last word.
No, I think I don't have anything to add specifically on this one. So.
Okay, well, I'd like to thank all three of you. This has been a terrific session. Every time I listen to you folks, I learn more. And I look forward to continuing that. Lauren, anything further to do before we sign off?
No, I think that's it. Thank you
Okay.
both so much, or all of you.
And I'd like to thank all of you who have participated in this webinar today. It's greatly appreciated. Thank you very much, and have a great holiday.
Thanks, everyone.
Thank you.
Thank you,
Thank
Charles.
you.
Bye.
Bye.
Bye.